Capstone Review, Session 4, Urinalysis and Body Fluids. Well, now that we've talked about a complete urinalysis, the physical, chemical, and microscopic part of the urine, and we've talked about renal physiology, I thought it would be nice to review some of the disease processes that can occur with the kidney. This is certainly not an all-inclusive list. There are others. Your book has a lot more, but I felt that these were the most likely to be on your boards. So I have them listed here, and we will talk about each of these individually. After that, we will talk about body fluids briefly, and then we will be done with this review session for Capstone. Acute glomerulonephritis is basically just inflammation of the glomerulus for a variety of different reasons. It can follow a group A strep infection. That is why it is important when you have a sore throat to rule out or rule in group A strep. Some textbooks call acute glomerulonephritis due to group A strep infection a different, well, they call it that, but they consider it a completely separate entity. And in reality, it's just all glomerulonephritis. And as a matter of fact, there's many different things that could cause it, so I kind of bring them together here. Other tests that you can do to determine if it is caused by group A, other than the patient recently had a group A strep infection, would be an anti-streptolysin O titer or anti-group A streptococcal enzymes. However, the urine characteristics for acute glomerulonephritis, despite cause, would be blood in the urine, hematuria, protein in the urine, white blood cells would be present, and casts, most notably red blood cell casts. These disorders and disease states can get quite confusing, so for board-taking purposes and test-taking purposes, it's very important that you understand the differences. What you really should associate with acute glomerulonephritis is red blood cell casts. You will also see granular and hyaline casts with acute glomerulonephritis. Rapidly progressive glomerulonephritis is similar to acute glomerulonephritis, except it's a more serious condition and often or usually does result in renal failure. So it progresses. It is associated with autoimmune disorders like lupus. The difference here that you might see with this one versus acute glomerulonephritis is a much more elevated protein level in the urine. You also would see fibrillation products, cryoglobulins, and IgA immune complexes associated with this disorder. Acute interstitial nephritis. This is inflammation of the renal interstitium, and it may be caused by an allergic reaction to some medications. What you see in the urine is hematuria, proteinuria, white blood cells, predominantly eosinophils, and white blood cell casts. Membranous glomerulonephritis. This is when the glomerular capillary has a thickening of the walls in the basement membrane. It's associated with quite a few different disorders: lupus, syphilis, hepatitis B, gold and mercury treatments, malignancies, and Sjogren syndrome. What you see upon urinalysis is hematuria, proteinuria, and the way you can diagnose this is diagnosing or detecting the secondary disorder. So having these features and knowing that the patient has syphilis or lupus or any of the others that are listed there. Nephrotic syndrome. This is when a person has irregularities in their blood pressure, usually massive irregularities like going into shock. Nephrotic syndrome, the urinalysis is going to review marked proteinuria. We're talking massive amounts of protein in the urine, greater than 3.5 grams per 24 hours. So that is one thing that you want to look for when you're taking a look at case studies and scenarios for your boards and exams, is that protein. How much protein is there? If they say a lot, you probably want to start thinking about nephrotic syndrome. You're going to see blood in the urine, lipids in the urine as well, oval fat bodies, renal tubular epithelial cells, epithelial fatty and waxy casts. So a lot of things going on here. This is a pretty severe syndrome, and again, think of that massive amount of protein for nephrotic syndrome. Focal segmental glomerulonephritis. This is when only certain numbers of glomeruli are affected, but not the entire glomerulus, hence the name focal. It's often seen with HIV patients, and it is associated with abuse. You'll see blood in the urine and protein in the urine. Chronic glomerulonephritis, also known as Berger disease. This is long-term, and it's a progressive loss of renal function. You see blood in the urine, protein in the urine, glucose in the urine, and a variety of different casts, including and probably most notably broad casts. Acute pyelonephritis. This is an infection of the renal tubules, and we all know if those aren't working right, you have problems. This is your classic kidney infection. It's caused by a urinary tract infection that made its way all the way up to the kidneys. You will see blood in the urine, protein in the urine, white blood cells in the urine, bacteria, casts, most notably white blood cell and bacterial casts. Chronic pyelonephritis is a chronic infection of the tubules and the interstitial tissue. This may progress to renal failure. Again, blood, protein, white blood cells, bacteria in the urine, and all different kinds of casts present. White cell, bacterial, granular, waxy, and broad casts. And finally, outright renal failure. This is when you could have tubular necrosis caused by toxic agents, or renal failure can be a result of disease processes. Some of them renal diseases, some of them not renal diseases. And basically what it is an outright failure of the kidneys to filter blood. The symptoms of renal failure certainly can be varied or variable. They're going to mimic the primary cause and be very similar to any of the other disorders that we talked about. Blood in the urine, white cells in the urine, maybe immunoglobulin complexes in the urine, complement. And it just kind of depends on what's causing the renal failure in the first place. That was a very brief overview of some pathologic conditions associated with the renal system. Remember, there are a lot more. I would advise you to study those. Your book has some really nice tables and some overviews of all of those disorders. I tried to highlight the most common ones. I tried to highlight what I thought would be more than likely on your board of certification exam, but I don't have a crystal ball either, so I'm not really sure. Definitely take some time to review those in your text, but just remember, again, 9% of your exam. How many questions could there possibly be? All right, so let's move on to body fluids. The first fluid we're going to talk about is cerebrospinal fluid, CSF. This is an ultrafiltrate of plasma, which is made by the brain's third choroid plexus. It has several functions that are pretty important. It supplies nutrients to nervous tissue. It acts as a system to remove waste, and it acts as a nice buffering system or a cushion for the brain. 20 milliliters are produced every hour in adults, and the normal range for volume in an adult is 150 to 170 milliliters. The collection of spinal fluid is important. It is done via lumbar puncture. This is done by a physician, not the free staff, obviously. The physician goes between the third and fourth or the fourth and fifth vertebrae. The fluid is collected into sterile numbered tubes, and it is very, very important that those tubes come to the laboratory labeled properly and numbered. This is not a time to get all haughty and think, oh my gosh, they did this tube perfectly, I'm going to throw it in the garbage. This patient just underwent a surgical invasive procedure, and a lot of times when individuals are very ill, it is not always easy to collect spinal fluid. So you have to keep that in mind. With that said, it is very important that the laboratory and the surgical staff and the physicians that perform this procedure are in direct communications and have very clear directions and expectations of what needs to take place as far as these tubes go. Tube number 1 goes to chemistry and serology. Tube number 2 goes to microbiology. Tube number 3 goes to hematology. And tube number 3 is also paired to tube number 1 if, in fact, there was a traumatic tap or if it was suspected. Tube number 4 isn't always obtained, but if you're lucky, you do get 4 tubes, maybe even more. And that goes to special chemistries and miscellaneous testing. Spinal fluid under normal conditions should be clear and colorless. At times you can have samples submitted that are cloudy, and this is indicating cells, red cells, white cells, protein, and possibly bacteria, any or all of the above. Sometimes you can get a bloody sample. This can either be due to hemorrhage taking place, and in this case all of the tubes should appear bloody, or it can be due to a traumatic tap. If the tap was traumatic, the tubes in progression should become less bloody. So tube number 1 should appear somewhat bloody. Tube number 3 should be much less bloody than the first one, and so on and so forth. Another descriptor that we use often for spinal fluid is xanthochromic. This is a yellowish color. This is due to either increased hemoglobin, bilirubin, or protein. Spinal fluid samples will also turn yellowish or xanthochromic if they sit for long periods of time, not analyzed immediately. Every laboratory that I've ever worked in my entire 17 years, spinal fluids are treated as stat. There's never been a time that I can ever remember where a spinal fluid didn't come in. You drop everything and you process it immediately. There's a lot of testing that goes on in all parts of the laboratory for spinal fluid analysis. In chemistry, the glucose is analyzed and the total protein is analyzed. And those values can give the physician very important clues as to what is going on with that individual. 60-70% of the plasma glucose should be the amount of glucose circulating in spinal fluid. And for protein, I just dropped my notes. Let me find it again here for you, sorry. Let's see, protein. Normal values for spinal fluid protein are 15 to 45 milligrams per deciliter. Higher values are found in infants and the elderly. Similar to those found in serum. And so there is a reference range for that. Okay. The clinical significance of elevated protein values are most frequently in pathologic conditions. If it's low, that is indicating that there is fluid leaking from the central nervous system. Usually if it's high, it has to do with damage to the blood-brain barrier or immunoglobulin production. When I think of elevated protein in the spinal fluid, I automatically think of meningitis. But there certainly are other reasons why it could be elevated, but think meningitis. In the hematology department, we're going to do a cell count. Now, there are laboratories out there and there are instruments out there that are capable of doing cell counts via automation. Back in my day, when I was in the lab, we all did them manually, and I know that when I was leaving the laboratory to be an instructor full-time, they were testing and doing comparison studies on a lot of different analyzers to make sure that they were counting cells in these fluids accurately. So if you're lucky enough to work in a laboratory where you get to do automated cell counts for body fluids, good for you, but you still need to know how to do the manual count. You use a hemocytometer, and there are calculations for this similar to the manual red blood cell counts. At any rate, you get a cell count, you're counting the white blood cells. We're not really interested in counting the red cells. We also need to do a differential. So out of the white blood cells, which predominate? And normally, you can see 0 to 5 white blood cells per microliter in normal spinal fluid, and what should predominate is lymphocytes and myocytes. Abnormally, you would have greater than 5 white blood cells per microliter, and if you have a predominance of lymphocytes, that is usually due to viral and fungal infections. If you have an increased number on the differential for neutrophils, that is indicating bacterial infection. If you're seeing immature cells, that can indicate leukemia. And if you're seeing a lot of plasma cells, that is indicative of lymphocytic reactions or a multiple sclerosis. Microbiology, we're going to do a gram stain stat, and you're looking for bacteria and reporting out the morphology and the gram result of that bacteria. Obviously, a culture is also going to be done, but as we all know, culture results aren't going to be back for a couple of days, probably at least a day, if not more. Another thing that is pretty routine in the microbiology area, and that would also be done stat, would be an India ink prep. And this is adding sample to a drop of India ink, and we're looking for Cryptococcus neoformans. And this is a possible complication of AIDS. AIDS individuals are immunocompromised and are more highly susceptible to Cryptococcus infections. And if you're not remembering, Cryptococcus neoformans is so, and I have a nice image there of what India ink prep would look like. This would be positive for Cryptococcus. And what happens is Cryptococcus neoformans has a really nice capsule around it, and so the India ink is unable to penetrate that capsule. And you can see kind of that halo effect. Some microbiology labs will also have antigen testing available, and the labs that I've worked in that have employed this, that antigen testing was also stat. However, it was also very time-consuming, and it was really important that the physicians understood this. The antigen testing that I remember doing, took at least a half an hour to 45 minutes before you came up with the result. And what they were looking to detect antigen to Neisseria meningitidis. All right. That was short and sweet, and we're going to move on to seminal fluid. Why in the world do we even bother? Well, we want to evaluate infertility. We want to evaluate the success of vasectomy patients and also for forensics. Most clinical laboratories are not involved in the forensics aspect, but certainly bigger laboratories are involved in infertility testing for men, and most laboratories, even small clinics, these days are doing post-VAS samples, and that's just a simple taking a look at the slide and just looking for sperm. If you see one, you report it. Yes, sperm was present. You're pretty much done with that sample. If you don't see any is when you're kind of grumbling because you're looking. You have to evaluate the entire slide before you can say no sperm is present. And I'll tell you, that's pretty important for them who are not interested in having any more babies. They want to make sure that that operation was successful. Specimen collection, it must be collected in a sterile container via masturbation. Condoms should not be used. It will alter the specimen. For infertility patients, they need to follow the instructions, and usually those instructions are going to come from the laboratory or perhaps the endocrinologist or the fertility expert. Usually this requires 2 to 5 days of abstinence, no longer than 5 days, and usually not less than 2 days. It's good to know that for post-VAS specimens, there's no waiting period at all. And there's just certain intervals where the physician will order post-VAS specimens. The sample, once you receive it in the laboratory, it needs to be kept at room temperature. The patient needs to follow the instructions to deliver that sample to the lab within 1 hour. Some labs have protocols to have it there within 30 minutes. So what this means is the patient, if they can go home and collect this sample, great, and they can get it to the lab within that time frame and follow those directions, wonderful. They can certainly do that. That's generally not feasible for everybody, so most facilities are going to have a room, a special room or whatever for those gentlemen to do their thing and get a sample. It's important that you maintain composure and professionalism when we're talking about this. You know, it might seem kind of silly and people giggle and, oh my gosh, I'm getting a semen sample. But you need to understand that this is very important for these people, especially when battling infertility, and you need to maintain your professionalism at all times. So what we do for a semen analysis is going to kind of depend on, again, the type of sample you get. This table here is mostly for fertility samples. You're going to measure how much of the volume, how much semen did the person collect. The normal range is 2 to 5 milliliters. You're also going to note and record the viscosity of the sample, and there is a policy or a procedure for this. You don't want to see any clumping or strings. Before you can do this, the sample must liquefy, and usually liquefaction or liquefaction occurs within 30 to 60 minutes. So even though the patient is instructed to deliver that sample immediately to the laboratory, you know, within 30, maybe 60 minutes, if they do deliver it immediately, it sits there at room temperature, or I know some labs have put it in a 37-degree cell incubator, and you have to wait for it to liquefy to analyze it. You also want to note the appearance of the sample, the color and the clarity. Normally, it should appear translucent or grayish, whitish color. The normal pH value is anywhere from 7.2 to 8. And then, of course, count needs to be performed. And a lot of laboratories will have very special microscopes for this. I have worked in a few laboratories that had these microscopes, and I did have the liberty of doing some of these samples. However, this normally is reserved for individuals that sort of specialize in this. So a count is done 20 to 160 million per milliliter is normal, 10 to 20 million per milliliter is borderline. That's what those gentlemen are waiting for. Is there enough? And not only is there enough sperm, are they motile? Are they going to be able to do their job? And motility is graded and based on the percentage of the sperm moving. 50 to 60% are greater that are moving. A grade of 2 is normal. 0 is immobile. A score of 4 is mobile with strong progressive movement. So that's what we want to see for infertility and we're trying to rule out is the couple infertile because of the man or the woman, and there's all kinds of different tests for that. Morphology is equally as important as motility and count. There are lots of different shapes of sperm. Normally, they should be oval-shaped. They should have an oval-shaped head and a long flagellar tail and have that nice, strong, progressive movement. There are all kinds of different morphologies. I would refer to you at this time to your textbook. They have some nice diagrams in there. Again, yes, I think it's important to be aware of all this and certainly appreciate it, but in my experience, usually this is done in a larger facility and also usually done by specialists or people that are doing this all the time, and they're not just pulling a bench tech from chemistry or whatever to do fertility analysis on sperm. Synovial fluid, also known as joint fluid. So this is the fluid that lubricates and transports nutrients to your articular cartilage. It is also a plasma filtrate. There's lots of different reasons why you might need to remove synovial fluid, most notably too much of it accumulating. If you have too much fluid in your joints, that causes problems, stiffness and pain and inflammation. So this is done with a needle, usually via physician or nursing staff, and that fluid is aspirated and then sent to the laboratory. The normal appearance of synovial fluid is clear to straw in color, but it can be very varied levels of yellow or amber, depending on the condition. So we're going to take a look at what color it is. We're going to do a count and a differential, what kind of cells are present, if at all, your brand stain in a culture, and a crystal ID. So you're taking a look at, are there monosodium urate crystals there causing gout? And are there crystals there causing pseudogout? So on and so forth. So definitely for joint fluid, you're taking a look at that. Generally speaking, we're not doing any kind of chemistry analysis for synovial fluid, but we are taking a look at crystals. You do need to have a polarizing microscope to take a look at the crystals. Calcium pyrophosphate crystals could also be present, and that would be the cause of pseudogout. You could possibly also see cholesterol crystals, calcium oxalate crystals, and calcium apatite or calcium phosphate crystals as well. Those would be seen with osteoarthritis, and mostly, I would say in my experience, you're differentiating between the monosodium urate and the calcium pyrophosphate crystals. And of course, looking to see that, is it an infection causing that inflammation? Gastric fluid is something else that can be analyzed in the laboratory. This is usually done via a nasal or oral intubation. It is clinically significant for toxicology and diagnosing Zollinger-Ellison syndrome. You're going to take a look at the physical appearance, the volume. You're probably going to do pH and not pH paper. You're going to use a pH meter for this and determine the acidity of that fluid. Amniotic fluid. is becoming more and more routine in the laboratory. That is the protective fluid around the fetus. The process to obtain this fluid is amniocentesis, performed by a physician. It is most often submitted for genetic studies. It's also used to assess the condition of the fetus. So we're looking at things like fetal lung maturity. Is there an infection in the fluid? A fetal bleed, and how much of a fetal bleed there is. Is there meconium? Meconium is fetal stool, and it's not good for the fetus to aspirate meconium. We're also looking at bilirubin that can be useful in assessing liver maturity and phospholipid levels. So there are lots of screening tests today for amniotic fluid, but usually that is reserved for much larger laboratories. Otherwise, I'm pretty used to amniotic fluid being a send-out test. I'm sure those of you who have had babies may or may not have had the opportunity to have amniocentesis done. It was certainly offered to me. I declined. I didn't really want to know if there were any abnormalities, but certainly when there are issues with the fetus and you need to find out the fetal condition, it's pretty important. The next fluid we're going to talk about is peritoneal fluid. This is a fluid contained between the parietal and visceral membranes in the peritoneum. Peritoneum, also known as the abdomen. So between the walls of the abdomen, also known as ascites fluid. This fluid normally should appear clear to pale yellow. And what we're going to look for here, again, are cell counts in a differential, gram stain, probably a culture as well, looking for infection, the color, and the specific gravity. So there's a variety of different reasons why peritoneal fluid would accumulate. The one most notably that I would be thinking of is probably cancer. Pleural and pericardial fluids. This is the type of fluid that exists between the visceral and parietal membranes, the pleurum and the pericardium. Normally there is some amount of fluid here. It allows for those two membranes to coexist together and not rub against each other. It's clear to pale yellow in color, and the processes to obtain this fluid are thoracentesis and pericardiocentesis, respectively. We're going to take a look at cell count differentials, gram stain culture, and if you've ever worked in a laboratory that has inpatients, you see a lot of pleural fluid when you hear about fluid on the lung, and it's pretty hard to breathe when you have a lot of fluid on your lungs. And this is a source of great relief for those individuals just to have that thoracentesis done to draw that excess fluid. But the physician needs to figure out, why is there excess fluid? Is it due to bacteria? Is there an infection going on? Or possibly cancer? And of course, body fluids could also be submitted to the cytology department for those laboratories that have department. It's important to know the difference between effusions. So effusions are increased amounts of peritoneal, pleural, or pericardial fluids. So when you have too much of it, it's called an effusion. Exudates are when you have effusions that are inflammatory, meaning they have lots of cellular material, cells, and lots of protein. Non-inflammatory effusions are called transudates. They have fewer than 1,000 cells per microliter and less than 3 grams per deciliter of protein. Fecal analysis. This is important for detecting bleeding that occurs in the GI tract. It's important for detecting liver and biliary duct disorders, malabsorption syndromes, and infections. So I have an image there of an occult blood card. with some reactions on there, one looking very, very positive. Can't really tell if the other one is really blue enough. Both of them very well may be positive. So stool samples or fecal material should look normally brownish. There's all kinds of different colors that are associated with the food that we eat. However, there are some colors that should not be normal. Black tarry appearance of stool samples indicates therapy or upper GI bleeding. Red color of stool indicates lower GI bleeding. When you can visibly see fat, which is called steatorrhea in the stool, that is indicating a malabsorption issue, specifically meaning the individual is able to absorb fats in their GI system. Obviously, stool or fecal material can be watery. We call that diarrhea. If it looks ribbon-like, that means there's a bowel obstruction and is not being passed through the GI tract correctly. If there's mucus there, it is indicating inflammation or colitis or possibly infection. You can have clay-colored or pale stool samples, and that is indicating an obstruction of the bile duct or obstructive jaundice. Fecal leukocytes. If you see neutrophils upon examination, it's indicating bacterial intestinal lectins or ulcerative colitis or abscess. If there's no neutrophils, generally you still could have an infection though, because you could have toxin-producing bacteria. So the neutrophils are not going to show up. And also viruses can cause many enteric diseases that are horrible, and some parasites, and you wouldn't necessarily see neutrophil. Fecal fat analysis. This is detecting the fat malabsorption disorders. These samples get stained with Sudan 3 or oil red O, and you're looking for increased fecal fat in those samples. A lot of times this is a 24-hour collection, and greater than 3 droplets per high power field indicate steatorrhea, which is increased fat in the stool. Muscle fibers you may see in the stool. You can see this in normal amounts, but undigested muscle fibers can indicate pancreatic insufficiency. That can be seen in cystic fibrosis and also pancreatic cancer. Most commonly, outside of the microbiology department, the most common test that we're going to do on stool samples is going to be the occult blood or guaiac test. So this is a very nice early detection for colon cancer, and the methods are the orthotoluidine or the gum guaiac. Also have immunological tests for this and DNA testing for colon cancer. So I'm used to the orthotoluidine or the gum guaiac test. Sometimes some of the older physicians will actually refer to it as the guaiac test. They won't say fecal occult blood. I need a guaiac on that patient. So it's just a principle being employed. A lot of times nowadays the cards are sent home with the patients, and they collect their own sample and apply it onto the cards. And as some of you with experience out there know, this can be quite entertaining when you receive them in the mail. You're hoping that these patients follow directions, but makes it for an interesting day nonetheless. DNA testing can detect mutations associated with colorectal cancer. And so we get lots of these. Generally speaking, these are in the urinalysis department. Most labs that I've ever worked in have included the occult blood testing in the office. It's a quick development test. You just add a couple of drops onto the cartridge or the card, looking for that nice blue color. Sometimes they will submit gastric secretions as well for occult blood. Okay, so this rounds out our urinalysis and body fluids review session. I hope this has been helpful, and I look forward to hearing from all of you in the live Q&A session coming up soon.